Perimenopause is really a set of symptoms that most women experience, really nasty symptoms of perimenopause, where typically all of a sudden cycles start becoming irregular, night sweats, hot flashes, changes in mood and behavior, irritability, anxiety, insomnia, all sorts of things as hormones start to fluctuate. We're going to see the slow decline, especially of progesterone. It's just on a steady slope downhill. And when that poor female hits menopause, it just bottoms out at zero. We need to pay attention to our female patients. We need to understand what they're telling us. How can we be nuanced here and show up for our patients in the most appropriate way possible? Hey friends, welcome back to the Nico Misleh Podcast. It's me, Nico Misleh, here joining you today, and I've got another great subject to talk about. I want to talk about perimenopause. It's all the rage right now. At least it feels like it's all the rage right now. And for good reason, I think, because it's kind of been something that's just been brushed under the rug for decades and decades now. And I feel like it's finally coming to light. So first and foremost, a lot of you might be wondering, even as providers, like, what is perimenopause again? Like, remind me. It's not something we spend copious amounts of time learning in school, to be frank. And even if we do, we kind of just are taught that perimenopause is a stage in a female's life that is miserable and her hormones are declining, and you just tell her to hope and pray and move on. Well, first and foremost, I'm going to tell you that's definitely not what we're doing for female patients these days. That's a really bad idea and a total disservice to them. Perimenopause, typically is, again, a stage in a female's life cycle. So I kind of try to chunk these out in really like three stages. So there's pre-menopause, which is just a young female cycling regularly, having normal periods and all that sorts of stuff, ovulating, this, that, and the other. And that period of life, extends from, early puberty age to, depending on the lady, upwards of 40 plus potentially. Usually by 45 or 50, it's kind of over and done with. But so the vast majority of the first half, so to speak, of a female's life is spent in this pre-menopausal stage where she is cycling regularly. More or less, her hormones are relatively stable. And, if she's otherwise healthy and well, she's got her two halves of the cycle, right? Her follicular half and luteal half and all that good stuff. Okay. So first and foremost, I believe in the hormone replacement therapy world, those women were like not even someone we would take care of ever, right? It was almost always those ladies were just taught to suck it up. If something's really bad enough, we'll give you birth control. And we don't do that anymore either. Okay. So remember, bioidentical, specifically hormone replacement therapy, which is just actual hormone replacement therapy, right? We don't call progestins or conjugated equine estrogen. We don't call those bioidentical hormones because they're not hormones. They're hormone-like substances, okay? Bioidentical hormones are legitimately hormones in the greatest of sense, right? Anyways, let me get off that stump speech. So again, pre-menopause, kind of the first half of a young female's life leading into perimenopause, which is, it's kind of like purgatory, right? We're in this very weird position somewhere between, 40s to 50s. Again, the age is not very determined in the sense that it's not like you just hit 55 and all of a sudden you're in perimenopause, or 45 and you're in perimenopause. It can happen at many different times in a female's life. It could happen even in the late 30s, but nonetheless, perimenopause is really a set of symptoms that most women experience. It can correlate with some blood work as well, certainly, where typically all of a sudden cycles start becoming irregular. So that's one sign of perimenopause. So for example, oh, Nico, I've always had a cycle. It's always been 28 days long, blah, blah, blah. And now all of a sudden I skipped like 2 or 3 months. And then I bled, and then I had kind of a normal cycle, and then it stopped again for a month or two, and it came back. That's one of the first, I think, very obvious signs of perimenopause. On top of that, we can also have some really nasty symptoms of perimenopause. And those could be things like night sweats, hot flashes, vaginal dryness usually coming in kind of the later part of perimenopause as we enter into menopause, which I'll get to here in just a second. But again, those are kind of like telltale signs, like kind of the gold standard symptoms that we would be looking for if a woman might be in perimenopause. And then obviously there are a lot of other things that can coincide with this: changes in mood and behavior, irritability, anxiety, insomnia, changes in weight, right? Usually weight gain is what we're going to typically see. We could see changes in skin and hair and nails and all sorts of things as hormones start to fluctuate. In perimenopause, remember, what we're typically experiencing, what we're going to start seeing is where we used to have at least if you're a healthy female, very, very, very stable hormone levels. Now they go up and down, they peak and then they drop and so on and so forth, but they're very stable in the sense that they occur the same way, relatively speaking, day in and day out, week in and week out, month in, month out. Now, all of a sudden, what we're going to start seeing is estrogen, especially, becoming very erratic. So rather than, we have estrogen kind of peak and then drop, and then as that's dropping, progesterone peaks and then drops, all of a sudden, your estrogen starts kind of doing a roller coaster effect, right? Where it's, it could be super, super high. It could be 400 or 500 if we checked an estradiol, like on the serum. It could be extremely high one day, and then the next day we check it and it could be 2 or 3 or 0. That's how wild estradiol can be, especially in early perimenopause. Unlike progesterone, which again typically also has a peak and a trough and these nice stable levels as the weeks and months go on. And premenopause and perimenopause, progesterone really starts to just drop. So progesterone rarely has significant fluctuations in perimenopause. It is really estradiol that is starting to have very significant fluctuations, much more significant than the progesterone. So in many ways, we are in a state of relative progesterone deficiency in comparison to estradiol. So our estradiol, it's not to say that it's sufficient, right? Because in many days and many weeks, it might be quite low, or in many minutes and hours, it could be quite low, and in other hours, it could be quite high. But what we're getting ultimately is that we, generally speaking, have a slightly higher level of estrogen overall, on average, than we do progesterone. And this is where we start getting issues when it comes to temperature regulation. So both progesterone and estradiol, these beautiful female hormones, they both kind of co-regulate, both, by the way, male and female temperature regulation, thermoregulation. They have vastly different effects on mood and behavior. Remember, progesterone is calming, relaxing. It's a little bit more inhibitory. Estradiol is very excitatory and stimulating and all that sorts of stuff. So, of course, we can also even see changes in libido and whatnot. But perimenopause is a very, very, very difficult phase of life. And of course, I don't need to tell you that. My female patients could tell you that. It's extraordinarily challenging. It's kind of shocking how many marriages I think have been destroyed during that phase of life in perimenopause. And I'm not saying this is the female's fault. I'm just saying, we have a very unfortunate set of circumstances where the wife, God forbid, is going through perimenopause. Her personality and mood and behavior were very stable, and now they're becoming a little more erratic, and her poor emotions and things are labile, and the husband doesn't know what to do. And it feels like it's kind of this outside force coming into their marriage where really it's just, look, this is just a phase of life. This is just a hormone thing. And this is why I'm so passionate about hormone replacement therapy, because seriously, it can prevent what I believe to be totally catastrophic and tragic things happening within a marriage and relationship, and just not even just intimate relationships, but friends and family members. It can keep a lot of those terrible things from crumbling. And these poor women, these poor patients deserve that, seriously. And amongst all the other amazing health benefits that providing hormone replacement therapy provides for a female, just that very fact that, again, the fabric of their relationships can just be pulled apart over what is just a, unfortunately, but normal biological point in a female's life, which is perimenopause. So, think about all of a sudden you're not sleeping. You're not getting restful sleep at the very least, right? I have a lot of my female patients. One of the most common complaints I'll get when a woman is entering, especially into perimenopause, is they're just not sleeping. And I might ask them, well, Betty, what do you mean by you're not sleeping? Because you said you get 8 hours. But if you dig deeper, she might say, well, Nico, I think I sleep 8 hours, but honestly, I feel restless. And when I wake up, I feel drained, like I feel fatigued, right? So they might not be entering into the deep cycles of sleep that they need to be entering into. But many women are, again, experiencing what is just insomnia. They wake up and it's almost always around, that kind of late part of the morning, let's say 3 or 4 a.m. They're suddenly being awakened, where their progesterone would have typically kept them, again, in a relaxed and inhibited state where they can get nice deep rest. All of a sudden their cortisol spiking, and without anything to kind of block it, so to speak. And they experience this annoying wake up effect, and it's really difficult to fall back asleep. And then, of course, the worst part is they wake up feeling anxious. That's something that, again, for a lot of my female patients is new. And it's not to say that these females don't experience anxiety in other points in their life, but it might be so specific that, like, Nico, I've never felt this way, but I wake up and I feel anxious. Like I feel a dread almost, which is, again, it's fascinating to hear this stuff, because, again, some of these women are just, their whole life they've been very stable and everything's hunky dory. And now all of a sudden it feels like the wheels are falling off the wagon somehow. And so, again, these are common things you'll hear from some of these ladies. And it's just a no-brainer. I tell most of my female patients, they ask me, Nico, how will I know when I'm in perimenopause? Because there's really not a gold standard diagnosis of this, in the sense of, like, I can't draw blood work and just immediately be able to say, oh, Betty, you're in perimenopause. It's really a culmination of symptoms and some lab reference points that we could kind of assume that likely this is all pointing to perimenopause and age and all that stuff. But anyways, I tell my female patients, it's like love. You'll kind of know it when you're in it. And they kind of laugh. And then years later, they're like, oh my God, Nico, I know I'm in perimenopause. And I asked them, well, how do you know? And they said, it's like love. I just fell into it. And it's that kind of thing. It's that significant for most women. There are, by the way, a handful of women that I have in my clinic, and many of my colleagues have expressed this. There are females who, I'll be honest, they kind of breeze through it. I don't know what that is. I don't know if maybe their hormone levels are just not that erratic, or maybe they don't have great hormones anyway, so it just kind of carries over. But nonetheless, practically every female, if you really dig deep enough, they will have one of those several symptoms that I mentioned to you, a common complaint of some sort. And again, they might not tie back to perimenopause. They might just say, oh, well, I just deal with some insomnia. Well, when did that start? Well, it was probably a couple years ago, when my cycles became irregular, I stopped having cycles, that sort of thing. So again, perimenopause can last for years. It can last for a couple years. It can last for 3 or 4 years, 5 years. There's again, no like set range, so to speak. So it's something that we are very close with our patients with, and you should be, right? You should be very detailed in terms of how you approach perimenopause with them, and what are the signs and symptoms that we're looking for, and what are the goals that we're attempting to achieve, and how do we go about doing that. And I explore all this, by the way, in my master course, because it's really important that you know and understand this. Progesterone being like the top tier thing that we really want to be replacing. Okay. Progesterone is declining. It's just on a steady slope downhill. And when that poor female hits menopause, it just bottoms out at 0. I mean, there's practically no progesterone left at all. Now, estrogen, on the other hand, and this is confusing, a lot of people don't understand this, there will always be, relatively speaking, more estrogen than progesterone. Hear me out. The reason that's the case is because estrogen and estradiol is still being produced by, many of the tissues and local tissues, for example. So yes, even though the ovaries produce quite a lot of your estrogen at large, we still get androstenedione and different things like that, and testosterone and whatnot from adrenal glands and things of that nature. And we do have some conversion of that over to estradiol. Of course, if you gain a whole bunch of weight and whatnot, and you carry a lot of fatty tissue, which unfortunately a lot of females do, because of course they're losing so much of their pro-metabolic and anti-stress hormones like testosterone and progesterone and thyroid, all of a sudden they start getting that kind of menopause belly, and even in perimenopause, they can experience that. So at any rate, what I'm driving at here is that there's almost always going to be an estrogen excess in comparison to progesterone. Now, is it the amount of estrogen that was produced, in premenopause when that female was in her 20s and 30s? Of course not. Absolutely not. There were much higher levels there. However, those hormones were also in balance and in a good relationship with each other. We had progesterone and testosterone and allopregnanolone and all these amazing things, proper thyroid, keeping checks and balances on all of that. Whereas again, in perimenopause into menopause, we're not going to see that. We're going to see the slow decline, especially of progesterone, which is what is going to protect you from the kind of excess estrogen effects, the excess stress, right? Progesterone is going to really help balance cortisol and things of that nature. So it's something we want to give to our patients 110%. The common concern, and I'll address this specifically because, again, when I was brought up, a lot of my mentors weren't sure what to do. I had some mentors who said, you absolutely give estradiol to women in perimenopause, all of them. And I'll be honest, those women did not do very well. They were miserable. Some days was great. Other days were terrible. And I soon learned that one of the reasons that was the case is that, again, women in the especially very early to mid part of the perimenopause journey or cycle, so to speak, or phase of life, what they'll experience is, again, roller coaster effects of estrogen and estradiol, meaning it can be really, really high one day, it can be really, really low the next day. And again, it's kind of roller coastering, but slowly and surely declining over time. So again, the thought process was, well, how could we ever replace estradiol effectively if the levels are all over the place? And so then there was this other camp of providers who just said, well, you just don't give any estradiol to women in perimenopause at all. Blanket statement. I'll be honest with you, that did tend to pan out much better for the vast majority of female patients who I worked with, again, during my kind of rotations through my family nurse practitioner program up until when I started practicing. And I found that method was much more effective, right? Because again, it's just so hard to bullseye that estradiol. And certainly we're not going to get blood work done every day and all that sorts of stuff. Now, there are urine tests and things of that nature that I've seen that, potentially could help diagnose some of these things on the fly and whatnot. They're kind of, cumbersome, expensive, and all that sorts of stuff. Not a lot of my female patients would stick to that. And frankly, it didn't ever change my treatment plan. And what I mean by that is I always give my female patients estradiol if it is medically necessary and it is required. And how would I know that? And this is where I think the art of medicine is so important. We have to value these objective measures and tests. And test don't guess is my favorite thing in the world. I'm a big serum guy and whatever. I love testing for my patients, but there are times when a serum test is or even a urine test is not inherently always going to give you the full picture. At the end of the day, a urine test or a serum test is just going to show hormones in the urine or in the serum, and we hope that is to some degree a relatively good reflection of the internal state of this female. But again, because there are such things as progesterone receptor, estrogen receptor, androgen receptor sensitivity and resistance. Again, much like insulin resistance, there appears to be such a thing as hormone resistance at large. Just again, because we see a healthy serum level does not always equate, or a urine level, a dried urine level does not always equate to a healthy and optimal level for the female. I hope that makes sense. So again, what am I getting to? I'm getting to the fact that we need to pay attention to our female patients. We need to understand what they're telling us. Again, many of my female patients early on in perimenopause, they're not complaining of vaginal dryness. Really, most of them are not. That's not a big complaint. They might complain of decreased libido, but they're generally not complaining of vaginal dryness. Now, as a female enters into the later stages of perimenopause, so again, she may still be cycling very irregularly. At this point, it may have been 6 months since her last period, right? And we're probably like, oh, we're looking down the the barrel of the gun of menopause. But that female might say, Nico, over the last year or so, and especially over the last 6 months, I've just been really dealing with a lot of vaginal dryness. And maybe it's painful to have intercourse and all this sorts of stuff. And it's just really uncomfortable. Maybe she's even getting some UTIs for the first time ever. That would be a point in time where I would say, hey, even looking at your blood work, have I seen any trends where I'm like, okay, I've really been seeing your estradiol levels starting to dip. Now you're also telling me that you're experiencing some of these symptoms of low estradiol, and might I be able to replace that? And again, going in low and slow is really the key there. It is not a good idea to just give that lady what would be a full-blown menopause and beyond dose of estradiol right off the bat. So again, I'm a big fan of oral estradiol, but even some topical creams are fantastic, starting at a kind of lower dose and just seeing how that female responds. Again, some of my females might have to titrate that up and down a little bit just to kind of get that just right. But most of the time, what they should experience is, hey, vaginal dryness, totally good, like all better. Maybe I'm noticing my mood is a little bit more uplifted and so on and so forth. So again, I'm being nuanced here. What I'm saying is hormones are like never ever. It's just like a when and how and what's the goal, right? How can we be nuanced here and show up for our patients in the most appropriate way possible? And again, I think perimenopause, we shouldn't view it as either never ever or always. It should just be it depends. It depends on that patient's circumstances, symptoms, objective results, blah, blah, blah. And we then craft a plan around that, right? Of course, we all know this, but what I want my people, my providers, my students to get really, really comfortable with and confident with is the ability to sniff this stuff out, to assess for these things so they don't always feel like they have to rely on, just a blood serum level or something like that. We're not waiting for estradiol to hit zero and be zero forever, or an FSH to fall off the face of the earth, or an FSH to increase dramatically, right? Because that would be a sign of menopause. Menopause would be typically no period for at least 1 year. And then in combination with that, almost always a good idea is making sure you're checking an FSH, a follicle stimulating hormone, and making sure that it's at least above, say, 35 or so on average. Maybe over 50 even. Those are usually good enough signs to say, hey, you're likely in menopause at this point. It's pretty clear. And an estradiol is typically 0. Again, all that to say, when it comes to perimenopause, I want you to just step in for a moment and just consider that you have the ability and the critical thinking necessary to really think through and problem solve for these patients. And, the course, the HRT University Master Course and all this stuff, that's designed to help you get through those tough spots. Like, it's designed to help you become an expert. I think it's really not a great idea to be mediocre at HRT. Like, I really don't, especially when you're treating ladies. It's really challenging anyways. Like, you're going to miss the mark occasionally, and you just want to be able to course correct very quickly without feeling stressed out or anxious or feeling like you've let someone down. And again, a lot of that mostly just comes down to listening to the patient, really getting a sense of, where they're sitting in terms of their symptoms. How have their labs been trending? What have you been utilizing for them? And do you need to shift course just a little bit? So I'll mention this too when it comes to perimenopause. And again, practically every single stage in a human being's life. If they need thyroid, give them thyroid. But again, I find that a lot of providers are slow to the gun with thyroid. I think they're timid about prescribing it. And thyroid, again, is one of those amazing, it's just one of the most incredible tools that we have in our toolbox when it comes to the health of a human being. Thyroid is really the master and commander of our metabolism and of our energy. And remember, energy is the currency of life. It is what is really going to lead us into a path of optimal health or lead us astray into a path of disease and death. And so when it comes to perimenopause, if this is a new patient to you, you should absolutely be considering that along with all her other hormones, likely her thyroid is going to be suffering dramatically. And boy, oh boy, the difference it'll make when you add thyroid back in to a perimenopausal female's life is extraordinary. Right? We're going to see some weight loss. We're going to see that thyroid help kind of potentiate the effects of the progesterone, which of course is really what we're chasing after. The thyroid, remember, is massively important when it comes to your liver health. the health of the liver, the ability for the liver to properly detoxify. I remember when I used to work with, remember, I'm a functional med guy. So my mentors who I worked with back in the day, these guys were really, really crunchy. Today they would be considered like totally normal, but back in the day they were like, people thought of them as quacks, and they weren't. They were geniuses. They were amazing. But they always used to talk to me about detoxification and how important that is and how we support it. And it just sounded so hokey to me, right? It sounded like we were always talking about, like, I don't know, some conspiracy theory, and like we have to detox the mercury out of our brains and fluoride and stuff. Now I know most of that's actually kind of true. But at that time, I just remember thinking, the word detox just made me feel sick. But now I recognize how just amazing, first of all, those mentors were, those men and women in my life who really helped me understand this stuff at a very, very young age. I mean, I was in my 20s when I was learning this stuff. So 10 years ago. And now to see this stuff come to fruition and see all the changes that have been happening in the research, like, these guys were just so far ahead of their time. So anyways, shout out to my mentors. That you guys were amazing. But at any rate, they always used to talk about detox. And they always used to talk about how important the thyroid was. And again, one of my favorite mentors, who I never got to actually meet in person or really have dialogue with, but it feels like I did because I've spent so much time with him via YouTube interviews and podcasts and stuff, was Dr. Ray Peat. What an amazing character. But he always talked about the benefit of a healthy liver, and especially a healthy thyroid, because a healthy thyroid is what is also controlling that metabolic output and processing of the liver and supporting all those detox pathways. And, if you think about it, really, the liver's got a lot going on. It's a very energy hungry little spot in the body there. And when you have a crappy liver, not even just fatty liver, it's just kind of backed up. Maybe you've got a sluggish thyroid and your energy drops a little bit and your liver just can't keep up. All of a sudden, you'll start having an excess of estrogen buildup. And that is a huge problem, because as that estrogen builds up, it can also then start recirculating. Rather than clearing from the body, it is now just getting pumped right back in and causing, what a lot of people have considered, estrogen overload or estrogen dominance or something like that. Which, again, both of those terms, a lot of times I used to think those sounded kind of hokey and silly, but they're very real things. And at the end of the day, really what they are is just a lack of thyroid and a lack of progesterone that leads to the state of relative estrogen overload. So when it comes to thyroid and perimenopause, in perimenopause, again, our estrogen is fluctuating. It's dropping slowly, but it's really doing that kind of roller coaster effect. Well, at the very least, we want to be attempting to detox whatever's left over so that we can maintain some sense of stability in the serum and in the bloodstream and at the tissue level. But if you just keep having a crappy liver, kind of now not being able to pump out estrogen, now it's recirculating in your systemic system, it makes a lot of people feel like crap. It can cause a lot of that inflammation, histaminergic reactions. It can cause some of the, God forbid, like fibroids and benign tumor growths and stuff if it's really, really, really unhinged. So adding thyroid back in to support the liver, like both directly and indirectly, if the thyroid can help support the liver, help support some more of that detoxification process, that alone can make some women just feel like $1 million. So please, 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 please don't forget about thyroid for your patients. It's so important. It is one of the major pillars of health and wellness for all human beings, is the health and wellness of the thyroid. And again, I teach around optimal versus quote unquote normal. So it's probably the most controversial thing ever. And this video wasn't meant to be about a thyroid video, but let me just explain. In many ways, this is really fascinating. You'll read some studies where it says like thyroid is like totally overdone and overprescribed. It's overdiagnosed. So in modern conventional medical literature, that is a lot of times the standing point is like, oh, we overtreat thyroid, we overdiagnose it. It's not that big of a deal. And in my humble opinion, based on the literature that I'm looking at, and even just my real world examples of patients and people that come in to see us at the clinic, I would say, no, thyroid is severely underdiagnosed. And maybe I'll even make a point here. It might be, let's just play fair and say, okay, it's relatively well diagnosed. More specifically, it's poorly treated, right? In the conventional model, thyroid is no bueno. So even if you get diagnosed with, say, Hashimoto's disease or hypothyroidism, like overt classic hypothyroidism, almost always you're going to get what medication? Levothyroxine. Levothyroxine, it's typically not dosed high enough. Even if it is, it's just synthetic T4. And the synthetic part, by the way, is actually not the problem child so much as it is its only singularly isolated T4. Whereas something like a desiccated thyroid or a natural desiccated thyroid, that would be medications like NP thyroid or Armour thyroid, if you've ever heard of those. They've been around for, literally a desiccated thyroid has been around for hundreds, technically kind of thousands of years. It was even used in like ancient Chinese medicine. This has been a medicine that's been safe, well recorded, well studied, and it's again a combination of both T3, the active thyroid hormone, the one that really matters, and also T4. And when you take that together, it has a somewhat similar mimicking effect of your own natural thyroid production, right? Our thyroid doesn't just pop out T4 only, it produces both T3 and T4 in a kind of concerted ratio. So again, I find that even if patients are being diagnosed with hypothyroidism, which again, I think it's still way underdiagnosed. But even if we played ball and said, okay, fine, we have the same, we believe the same diagnosis rate is fair and reasonable, or it's maybe even overdiagnosed, it's still a problem because we rarely get patients into symptom resolution. When these providers give patients T4 or Synthroid or Levothyroxine only, what will happen? We'll see their TSH, let's say it's 4.5 or 5.5 or whatever, it's high. Let's just say it drops back to, I don't know, let's just say 3. Okay, and the reference range is, basically 1 to 4. Well, a lot of times a provider is going to say, job well done, dust his hands off, get back to work. And most of the patients are going to say, but doc, I don't feel very good. or nurse practitioner Sue, I feel terrible. Like I don't feel any better. Or maybe I felt better for like a week or two and now I feel terrible again. And a good doc might say, okay, I hear you. And they'll bump the dose up and the TSH might drop more. And again, the T4, if they even check it, might come up a little bit. And they'll say, okay, now how are you feeling? Well, if you say you don't feel any better at all, they're going to say, well, it's probably not your thyroid then. There's nothing I can do about it. Maybe you're depressed. Do you see how nasty this can get? It gets so confusing because, again, in HRT University, I'm going to show you like where exactly is an optimal range for free T3. It's what we're looking for is free T3 and much higher than you think. And also, what if my TSH goes to 0.001? Is that a problem? No, it's not. But again, it's so hard to overcome that because we've been taught for years and years and years, and our mentors have been taught for years and years and years that was really inappropriate. Never suppress a TSH because it could cause X, Y, or Z. And that's not true. That's only true if you have something called hyperthyroidism. If I give you medicine to replace your thyroid hormones and it drops your TSH, it doesn't invariably lead you to bad outcomes. It doesn't at all. In fact, the literature is really clear on that. That is only the case if you have excessively high amounts of T3 in your bloodstream and it starts eating away at your bones and things like that. So again, the proof is in the pudding, and also we have to just be considerate of the nuance. So when it comes to things like perimenopause, even the kind of, let's just call it an adjunct hormone like thyroid, which is so vital for females and especially females in perimenopause, we have to understand that there are a lot of controversies just in HRT alone, and then we have to dig into the controversies with just thyroid hormone, let alone estradiol and progesterone and testosterone, and when do we add these things? So first of all, give yourself a pat on the back for even considering HRT. If you've never done HRT before, if you're considering that, providing that to your patients, you're doing amazing. You're doing the right thing. This is awesome. And it's a lot of unlearning. You know what I mean? It's a lot of like taking all the junk that we were taught in school, throwing it aside, so to speak, and then kind of relearning a lot of information. But the way I'm going to present this information to you in the course is much like I am now. It's conversational. I want you to feel comfortable and confident with it. I'm going to use a lot of different analogies to help drive points home because, again, I want you to be extremely successful here. And these are all things, by the way, that you need to know to then tackle kind of some of the even bigger problems. So perimenopause, it's challenging. Don't get me wrong. It's very challenging, but I want you to be able to tackle premenstrual dysphoric disorder. I want you to be able to tackle PCOS, postpartum depression. Like there are so many things that women deal with throughout their life cycle. And I don't want you to feel like you can only show up for just one of those things. I want you to feel like, whether a woman is, 14 years old or 94 years old, I want you to feel like I got this. I can do this. I know how to do this. And it's also because I'm going to show you how all these things are kind of connected. So again, it doesn't feel like you're learning all these super separate things all day long. I really talk about how these things are so interwoven into each other that, again, from PCOS to PMDD to, whatever premenstrual dysphoric disorder, doesn't matter. You will understand really the root cause of some of this stuff and exactly how you need to show up as a provider with hormone replacement therapy to get like the absolute best out of your patients in terms of their outcomes. And they will thank you for it. They will really, really, really thank you for it. So again, perimenopause is just one of those points in the life cycle of a female that we really want to be paying attention to. Because again, it's so easy to overlook that. Again, if you know this, remember, most women are told that perimenopause is just something they have to deal with. Seriously, perimenopause is not something that is genuinely treated in the conventional medicine setting. And again, I'm not here trying to like poo-poo or disparage people in primary care or even OB-GYN. It's just not something we're taught. It's not something we're taught to do, right? We don't practice wellness medicine in the conventional setting. It's sick care medicine. And frankly, if you're in perimenopause, we just tell you you're getting older and that's just part of life. Now, if you're a real gunslinger, you may offer some birth control, which will just chemically castrate that female. So could it help with symptoms? Maybe a little bit, but that is definitely not the route we want to be going because that's really just masking the whole problem. I think even worse than that, I don't know if it's worse, but it's definitely not better, is these poor women get served an SSRI, an antidepressant. Maybe they get both, the double duo, right? You get an SSRI, an antidepressant, and birth control. And I feel sad about that. I feel sad, and it hurts me that's where we've ended up over all these amazing years of medical literature and research and study and all that stuff. That's where we've ended up. So I want you to know that you are a much, much bigger part of the solution to our problems at large right now. It is so easy for us to feel like really small fish in a really big pond. You are actually not a small fish. If you are doing hormone replacement therapy and you are helping out your local community or even national community of say just even females in perimenopause, you are doing an unbelievable service to the world. You are literally helping save relationships, which means you're helping saving, marriages, you're helping saving jobs, you're helping save people money. You're helping save people from, God forbid, ending up in a hospital or a psych ward because they feel so terrible. You're helping people avoid medications that would otherwise be just totally inappropriate, like SSRIs or antidepressants or birth control for something that is just clearly, obviously a normal stage in life, which is perimenopause. And all we need to do, the most appropriate therapy, is just add the hormones back that they're missing. So simple, so effective, and so safe. It's so safe. Again, another thing I want you guys to unlearn is that hormones are dangerous. They're not. They're not dangerous at all. In fact, if you really want to look at dangerous, like check out the black box warning on oral birth control or antidepressants. That's dangerous. We've proven that to be the case. And yet, again, we can hand these things out like candy because it's just a part of medicine at large right now. That's what's normal. I talked about this at a conference I just recently had because a lot of people will ask me this or tell me this, and I'm not taking like offense to it, but a lot of people will say, Nico, you practice alternative medicine. And I know what they're saying. What they're saying is like you're kind of going against the grain and all that sorts of stuff. And I love that. I appreciate that. I really do. But I actually want to normalize some language here for a second, because language is so powerful. Alternative medicine, in my humble opinion, is things that we don't have a lot of research on. We're not sure how well they work necessarily, but maybe we have some slight anecdotal evidence, or at the very least, we feel confident that this could improve our patients' lives. Okay. I think that's alternative medicine. So I think that alternative medicine right now would be considered giving a woman who is in perimenopause. She's 47 years old. She's suffering from night sweats, hot flashes, right? Mood, irritability, whatever. It's very clear she's in perimenopause. I look at her labs and her hormones are a disaster. Alternative medicine would be, in that particular situation, birth control and an SSRI. SSRIs, and I've talked about this before, I'm not disparaging SSRIs or saying that they're the scourge of humanity or anything like that at all. I'm not disparaging any of you who've prescribed them. I've prescribed them in the past. But what I want you to know is that they're not the most appropriate therapy for the condition of perimenopause. It doesn't make any sense, right? And I talked about this at the conference a little bit too. Appropriate versus inappropriate therapies. So, I talked about if you had a appendicitis. Okay, we all know what that is. If you're a medical provider, you know what appendicitis is, right? Right lower quadrant, pain, rebound tenderness, blah, blah, blah. If you have appendicitis and you go to practically any major hospital in North America today, and a surgeon comes up to you and he says, "Hey, it's nice to meet you. My name's Gary. I'm the surgeon. I'm going to cut you open from stem to stern," as my grandfather would say, right? "I'm going to crack open your chest. I'm going to take this giant scalpel and run it all the way down your midsection, open you up, and pull that appendix out." We would say, "Dr. Gary, I love you, but please don't do that." It's 2025. We don't need to do that anymore. We could do laparoscopic, right? Which are these teeny little incisions, super, super minimally invasive surgery, world renowned, no big deal. Even just it doesn't have to be laparoscopic. How about a really, really small incision over the actual area where the appendix is, not just opening me up wherever. And okay, why would we do that? Well, it's going to limit the risk of infection. It's going to increase my recovery time, right? All these amazing things. So if I open you up stem to stern, could that still be therapeutic? Of course. I mean, could he find the appendix, get it out, stitch you back up, and you live a long and healthy life afterwards? Absolutely. And that's what we did for decades, by the way. Is that the most appropriate therapy, or is that an inappropriate therapy? I would say that's an inappropriate therapy. Is it therapeutic? Sure. Maybe a little bit. Is it the most therapeutic thing? No. We've grown. Are SSRIs the most appropriate therapy for a hormonal condition? No, they are not at all. We don't really know how SSRIs work, number one, which is interesting in and of itself. And why would I give someone a medicine like an antidepressant that has no clinical indication for perimenopause? We can define and show you perimenopause, 10 different ways. So the most appropriate therapy would thus be hormone replacement therapy. And that is not alternative medicine, okay? That is actually conventional medicine. How do I feel so justified in saying that? Because that is what is in the literature and has been in the literature for the last arguably almost 20 to 30 years. And I'm talking specifically about bioidentical hormone replacement therapy, not hormone-like substances. That is not HRT. That's hormone-like substance therapy. And I don't like that. When I'm talking about bioidentical hormone replacement therapy, which is really, and again, a language thing here, true hormone replacement therapy, good old-fashioned, legitimate hormones. When I give those to people, based on the randomized control trials and the meta-analyses and all the literature that we've had over the last several decades, what we can say definitively is that they are both safe and therapeutic and appropriate for the condition of perimenopause and many other conditions even outside of that. hormonal conditions that require hormones. Okay. So again, I want you to change your mind around, are you providing something that is quackery and quote unquote alternative? Or in fact, is this one of the most conventional and rigorous things that you could do as a medical provider to show up? And by the way, I'm not disparaging alternative medicine. Like I do all kinds of things on that front. Okay. I filter my tap water, for God's sake. Okay. So you're preaching to the choir in one sense if you're like, hey, don't diss alternative. I love alternative stuff. Okay. But what I'm really trying to drive at here again is the language that we use around this. I want you to feel confident and competent and assured that what you're doing for your patients, what you're doing for your clinic and your business, this is the best possible thing that you could be doing. And I'm not just saying that because it's my humble professional opinion. I'm saying that based on the literature that is available, what is the most current stuff that we have and in our hands right now that we can say with great certainty, is this a good idea or a bad idea? HRT is one of the best ideas in the world. Okay. So I hope this helps. I hope this helps you understand perimenopause. I hope this helps you understand like what are the things we're looking for when it comes to I can't speak now. When it comes to perimenopause. And I also hope you're now looking at HRT in just a very different lens. Okay. I always say HRT isn't fringe and it's not optional. It's foundational. I want you to take that home with you. Okay. HRT is not fringe and it's not optional. It's foundational. We don't treat type 1 diabetics with, a broken pancreas. We don't just give them something besides insulin. I mean, we can, but why would we? When it's so clear and obvious that all we need to do is replace that little peptide or, relatively hormone to make that person's life exponentially better and have a greater quality of life. That's what I'm looking for. And that's what I want you looking for when it comes to women coming to you with whatever condition, be it perimenopause, be it issues with fertility, be it issues in menopause. I don't care what it is. Think about what is the most appropriate therapeutic response for this person and how can I show up for them? All right, guys, I hope that was helpful. Don't forget, if you're not already on Nico's daily email, which is my email that I write by hand every single morning, Monday through Friday, get on there. It's a great place to learn. I provide lots of information, just like the stuff I talked about right now. Super quick read. Just gets your day going and gets your head in a good place. You can opt in on the links below on the show notes. It's again, Nico's daily email, and it's free, totally free to you. I also have a Facebook group. That's awesome. It's a great place to kind of just dip your toes in and learn a little bit more about HRT University and interact with some of the previous students and current students. Again, a lovely, lovely place. It's totally free, again, to kind of hang out and just see what we're all about. And we post a lot of stuff in there too, like this podcast. Again, that's Nico's HRT University on Facebook. You can just jump in there. And then, of course, don't forget about hrtuniversity.com. That's where you can check out all the things that we offer, including our master course, which is the best thing that ever happened to hormone replacement therapy. We are redefining what it is to provide real, legitimate, top of the line, highest quality hormone replacement therapy education to you as a provider. I want that for you. I want you to be the best ever. I don't want it to be mediocre. Okay. So thank you guys so much again for joining and have a great day.